Okay, so hi everybody. Thank you for joining the SBA series. Today we're covering Mod A, so basically GP and pediatrics. I'm Iqra. I'm a final year med student, currently on elective, but I'm here in London, so happy to teach you guys. Please do stop me if you have any questions along the way, or otherwise there'll be time at the end for questions. I'll try my best. I'm an aspiring GP, so this isn't a bad session for me to do. Okay, so we're going to be doing this whole series in a module approach, so focusing on each modules as one. So next week we're doing Mod B. Each lecture, so actually it's not going to contain 30, it's going to be slightly shorter just because this was meant to be run by two people and now it's just me. So I've cut out some of the ones that were too complex for me because peds is not my strong suit. But I will teach you the things that I can teach you. And we have tried to make this based off of what is in the curriculum map, what I've seen come up in exams as well. So question one, I do not know how to do a poll and I'm on this on my own. So I think it would probably be best rather than trying to set up a poll if you guys can just shout out the answer, just take a guess. A 93-year-old man with a background of COPD, heart failure, dementia, and stage 3 CKD presents with vague abdominal pain. An abdominal ultrasound identifies multiple hypoechoic liver lesions consistent with liver mets. He is currently bedbound with QDS package of care. Which of the following is an appropriate reason to not investigate the cancer further? Might have an answer in the chat. Two. Okay, good. So we're seeing some twos. Yeah, perfect. Okay. Yeah, so we have so those of you that said two, that is correct. So it is just because it wouldn't make a difference to how we manage this patient. The reason being that because he has all these comorbidities and he's bedbound with QDS package. So we know that okay, number one, because it's liver mets, we know that it's not going to be curative cancer because it's a metastatic cancer. And we also know that he probably wouldn't be fit for any even palliative treatment with this kind of, with all of these pre-morbid conditions. So it means that why would we, for example, do something that's invasive and uncomfortable and causing more harm than good? And so that's really the thought process here. Apart from that, like obviously it doesn't really matter if your presenting complaint isn't related to cancer, obviously you're still going to investigate cancer. CKD, we can always look at other ways of investigating. DNA CPR is for a very specific situation where your heart stops, but it doesn't affect everything else that you do up until that point. And even if I mean, yeah, so here, obviously, we can't assume that he doesn't have capacity just because of his dementia, but also, even if we didn't, we could still consider treating him in his best interests. Okay, moving on to question two. So, a 67-year-old man presents to the GP as part of a routine checkup for his type 2 diabetes. He's currently on metformin, his HbA1c is 47, and his blood pressure is 152 over 89. So, what is the next best step in his management? Okay, we've got a few mixed answers here. I'll give it a few more seconds. Okay, so the majority of you guys have gone for two. That is probably our next best answer, but our very best answer would actually be four, which one of you did get, so well done. So the reason being, and this actually threw me off as well, is that we always think like, let's treat the hypertension, but actually we need to confirm that he does have hypertension. Remember, he's in a GP, it's a one-off blood pressure. So the first thing that you're actually going to do is investigate further and establish that he actually does have high blood pressure, because this could be a one-off sort of white coat hypertension. And so you're going to do ambulatory blood pressure monitoring or get him to measure his own blood pressure at home and bring it in like a week later. And then you can see, is your blood pressure consistently high? But apart from that, those of you that put two, good job, because it means that you sort of are thinking about what type of hypertensive might you need. But unfortunately, because he's got diabetes, even though he is over 55, you'd want to start. Wait, no. No, so you would want to do ramipril. So you are right about that. I was thinking, I was like, I don't know. Right. So you would want to do ramipril, but it's just that you wouldn't start that treatment quite so soon. But I am glad that none of you guys went for one. So yeah, his HbA1c is within target. So it's 48 if it's on one medication, and if it's on two, what's the new cutoff? Just answer in the chat. So if we add another medication, yeah, great. Someone said so. The new cutoff is 53. So it depends on whether he's just on metformin or whether he's on metformin and another medication. All right. So just a little bit about hypertension sort of investigating. So if their clinic reading is high, you just double check that it really is high. And then based on the staging, you can then decide whether you're going to treat. So if it's just stage 1 hypertension, unless they have any of these comorbidities. So in this case, he has diabetes, so you'd still be treating. But for example, you also want to check sort of eyes and things like that, and double check, like, do you have any complications of hypertension? If it's above stage 2, you just treat, and yeah, if it's, I mean, God forbid, if it's a stage 3, you might need to like send them to a hospital. Okay, so question 3. Janet is a 37-year-old lady who has come to the GP complaining of unexplained bruises on her shins. They are tender to touch. Her only medical history is that she has had cold sores in the past. How should Janet be managed? Okay, this one's quite tough. So I've got a few threes, a few fours. Um, what do we think that this question is trying to describe to us? What is this mysterious bruising on her shins? Okay, good. Yeah. So I've got one answer. Anyone else? Yeah, good. Yeah, so erythema nodosum. One other person has put pretibial myxedema, which is a really good answer, which is why we've got TFTs, because it is one of your differentials. But in terms of common things being common, and the fact that she's not mentioned any other symptoms, like her only past medical history is the cold sores, she's not come in with anything else. I think we're assuming it's not pretibial myxedema, but it is an option here. So that's why we've got the TFTs, but I would rule that out because I'm thinking, this doesn't really sound like hypothyroidism. Routine referral to dermatology, to be honest. So I don't know if I've said this at this point. It is erythema nodosum. You guys are right. You wouldn't send erythema nodosum to a dermatologist. They wouldn't know, like, what are they going to do about that? So the answer here is actually, so I was split between 3 and 4, but the answer here is actually just 3. Reason being that, like, with the chest x-ray, again, you're just thinking about the lady's symptoms that she's coming in with. She's not got anything like to suggest sarcoidosis or TB, although that is a common cause of erythema nodosum. And by common, I mean maybe common in an SBA world, but actually much more common in real life is just herpes simplex virus. And so this is something that I definitely didn't get a grasp of until probably this year, that like erythema nodosum doesn't always equal sarcoid, which is what I always thought it did, because of the way that we learn is like, obviously we learn like these links, but actually there are so many causes of erythema nodosum. So what is it? It's just inflammation of the subcutaneous fat. And so they're quite often described as like raised red nodules. It does normally typically affect the shins, but it could be somewhere else. And they go away on their own. They don't cause a problem. And so that's why we can reassure and discharge, because they're not going to cause a problem. They're just sometimes a symptom of something else going on. And so we can just manage it conservatively. Now, in terms of the causes, sometimes we just never know what caused it. It just happens and it goes away. Sometimes it can be the medications that we give people, including the oral contraceptive. It can be pregnancy. We always know it related to sarcoid. It can be related to IBD and vasculitis. But the most common cause of erythema nodosum is herpes simplex virus, which is where the cold sores are coming in. Okay, moving on. Please stop me if you have any questions. I'm just going to assume that you don't. So butt in if you do have a question. Okay, so question 4. Penny is a 14-year-old girl who has attended the practice asking for regular contraception before her and her 15-year-old boyfriend start having sex. She says that this is a consensual relationship and her parents have met her boyfriend. However, she does not want to tell them about this. What other criteria need to be met in order for the GP to prescribe her contraception? So this is testing like a very specific, just pediatric safeguarding thing that you guys need to know about. And you're all getting it right. So you're right, it is 2. So this is testing your Fraser guideline knowledge. So even though yes, of course, we'd say, do you want to talk to your parents? Are you sure you don't want to talk to your parents? We would never, we, of course, will still prescribe a contraception because it's not in her best interest not to receive that just because she doesn't want to speak to her parents. And it might not be the safest option for some people. This is like it's like a very odd thing in the Fraser guidelines in the sense of it feels awkward. Like, how are you going to ask that in a way that isn't weird? So my mom is a sexual health doctor. And so I asked her this when I was preparing for my 5th year exams. I was like, do you explicitly ask, like, are you going to have sex regardless of whether we give you contraception? And from sexual health doctor to you guys, I'm going to tell you, she does not do that. She's like, this is kind of a given because they've come into our clinic. So we do not explicitly ask this because that is a bizarre question to ask. But the rest of the Fraser guideline, very relevant. This bit odd. It's not something people explicitly ask. It's something that we kind of assume clinically based on the vibes we're getting from the patient. However, it is something that you need to be aware of. And it's something that if you did have an OSCE, which I don't think you would, but if you did have an OSCE about this, you should probably just straight up ask, like, in a polite way, in a roundabout way, like, if we didn't provide you with contraception, would that sort of put you off having sex? And if they're like, no, then you're like, cool, we'll prescribe it. But I just thought I'd put that out there that actually I've asked about this because I think it's a bit of a strange like thing to check with your patient. Anyway, so Gilead competence versus Fraser guidelines. So Gilead competence is basically anything to do with medicine, whereas Fraser guidelines is only to do with contraception and sexual health. So Gilead competence is about whether people have capacity, essentially, because capacity is assumed in adults, but it's not assumed in a child. And the way that you measure or like check for Gilead competence is essentially the same as just normal how you check for capacity. It's just you actually do have to perform that check, whereas you don't in an adult. So it's just making sure that they, understand, are able to communicate, are able to weigh up and retain that information. Fraser guidelines is specific to sexual health and it involves these things. So number 1, as we've said, they can't be persuaded to talk to their parents. They understand, obviously, that's just part of your consent. Their physical or mental health or both might suffer from not receiving. So in this case, that's always the case if you think your patient's going to have sex without contraception. Like, that's obviously putting their physical and their mental health at risk if they have an unwanted pregnancy. So that is why that's pretty much always that box is ticked. It is in their best interest that you still treat them, which, as I've said, it will be, and that they're likely to have sex with or without the treatment. And remember that, yes, your patients come in for contraception, but you still need to advise them about STI risk because if they're not using a condom, then they're at risk of that. And always consider if this is a safeguarding issue. So going back to this, obviously this is 14, 15, they're in a consensual relationship, the parents have met the boyfriend, so everything sort of there's nothing super suspicious there. Whereas if, for example, the boyfriend is a secret, none of their friends know about them, none of their parents know about them, or if, for example, if there's a big age gap, then you'd be worried about, is this, is this not above board? In which case you really need to, and if you're ever in doubt, just get involved with the safeguarding lead at every clinic, anywhere, there will be a safeguarding lead. So anyone under 13 immediately has to be referred, whether or not, even if it is like consensual and it's with like another 13-year-old, that's still like, and if you're worried about grooming, or if you just pick up on odd cases. So for example, repeated STIs or termination of pregnancies. Also, one thing to look out for is like repeated UTIs in like quite a young girl, because why do they keep getting these UTIs? That's another thing to look out for. Okay, question 5. So Brian has come to the GP complaining of chest pain. It usually occurs when he's playing tennis with his friends, but is better when he takes his GTN. However, his chest pain has not subsided since this morning despite taking his GTN. How should he be managed? Great. I'm glad you guys have not fallen for the trap here. So this is your typical GP question. Like one of the really things that they like to catch you out with is you are at the GP. So the first thing is, where am I and how is that going to affect how I'm going to attend, like how am I going to deal with this problem? And so because he's in GP, like yes, you can go down your whole Mona dabs, but that's not going to do anything because he's literally in GP. You can't do that there. So the first thing is look at the setting and call an ambulance. So I think between 2 and 5, there are some. So the reason that you're saying 2 is because you think that they might be currently having a heart attack and that they can suddenly deteriorate very quickly. And if for example, they were in a taxi and they deteriorate, that is like you are on the like you're in trouble for that, right? Like you were sort of responsible for them and you let them go somewhere where they now can't receive any medical help. So that is why it's 2 and not 5. It's difficult because obviously in the NHS as it is currently, that is sometimes not the faster way. So, I remember when I was on my GP placement, the GP was like, we waited from 5 p.m. till 9 p.m. And obviously the surgery shut at 5, but I had to sit here with the patient because I was worried about them and they needed an ambulance, but I couldn't send them in that taxi, even though that would have gotten them to A&E faster. So it's really difficult. Sometimes you do find that GPs will recommend people to make their own way to A&E, but definitely for the sake of an SBA, it's always call an ambulance and not tell them to go themselves. And just in general, like for the sake of your own like professional, how liable you are, they really ought to be with someone who can help them. So even if that means being in the clinic and not in a taxi. Okay. So a little bit about ACS, quick revision from your 4th year. So first of all, ACS is your unstable angina, your NSTEMI, and your STEMI. There is, of course, stable angina, which is what Brian here had previously, where you have chest pain on exertion, but it's fine if you rest or if you take a little bit of sublingual GTN. Importantly, if you did test their troponins, it would be normal. And essentially, you just need to advise them about how they take their GTN, and you safety net them that if it isn't working, that you try again in 5 minutes. And if that's still not working, then you call an ambulance. With your ACS itself, so the way that I've always differentiated between unstable angina and NSTEMI is that it's the difference in troponin. So unstable angina might not have ECG changes, but I have seen it where it sometimes has. But the thing is, it shouldn't have changes to the troponins because it's not actually causing like ischemia quite yet, where it's causing like damage to the tissue. So there's ischemia, but it's sort of pre-damage. So, and then an NSTEMI, the way that I would differentiate is based on the troponins. And then your STEMI, you will see the STEMI because it's your ST elevation. And then in terms of management, it's sort of your Mona dabs. So Mona C for your primary prevention. So your morphine, oxygen if they're desaturating, nitrates if they're sort of hypertensive, and then your aspirin and clopidogrel or another, so for example, prasugrel or ticagrelor. And then calculate the grace score for an NSTEMI or send them for stenting in a STEMI. You don't really need to know these in great detail for this year, to be honest. Never bad to know it, but I shouldn't expect that this would come up. But this very easily could, just because it's about sort of knowing where you are and what's available to you at that moment in time. So Question 6. Paulina is a 30-year-old lady who has come in for her first smear test. She's apprehensive and wants to know more about what the GP is testing for. Which is the most common organism which causes cervical cancer? Yeah, you guys are really quick and all correct. All of you are correct. So it is HPV 16. So I don't for one, I would not personally be telling my patient which types of HPV cause it, but sure. This seems like a UCL type question though, where it's sort of, well, you're not going to say that to your patient, but okay. Um, Facts. So cervical cancer. So this is actually, to be fair, as a GP, you are going to be having a lot of these conversations. I just wouldn't get into the nitty-gritty with them, but you are going to be having conversations with people about what the smear test is and what the benefit of it is. So it's a 3-yearly screening test for women under 50 and a 5-year screening test for people over it. And you're essentially testing first for HPV, and then if they're positive for HPV, then you have a look at the cells themselves. And it's because you're trying to um like catch like dysplasia early before it becomes cancerous. And so it's all in sort of checking for cervical cancer. So HPV is like a really large part of what causes cervical cancer, mainly 16 and 18 and 33. HPV can also cause lots of other cancers, and that is why they have started. So originally they only vaccinate, like when I was in school, they only vaccinated girls because they were like only girls have cervices, and so why do the boys need HPV vaccination? But now they vaccinate both. For one thing, because it prevents sort of the spread like any other vaccine. Like just because boys don't have cervices doesn't mean that they don't spread HPV. And then also because boys do have anuses and mouths and throats. So actually, HPV is related to all these cancers, and so it didn't make sense to only vaccinate the girls. Other risk factors for cervical cancer, so smoking, HIV. I think the early first intercourse and many sexual partners, I think that's actually just related to your risk of having HPV. High parity, low socioeconomic status, combined oral contraceptive. And yeah, as I said, so you do test. So this was a recent change when I was doing this learning. So you test for HPV first, and then you send it for cytology. And if it's normal, then it's so if it's normal, but obviously you only know it's normal because you tested positive for HPV, then you repeat in 12 months to see essentially if they've gotten rid of HPV, because people do get rid of it themselves. If it's abnormal, then they'll need to be sent for a colposcopy where they'll have a proper look at the cervix and take a sample if needed. And then if it's inadequate sample, that's not that interesting or necessary to know, to be honest. But yeah, cervical cancer. Question 7. So, James is a 64-year-old man who has had a persistent cough for the past 3 weeks. On further questioning, he reveals a 6-kilogram weight loss, but otherwise feels quite well and has no shortness of breath or chest pain. He has no smoking history and has no significant family history. What is the next best step in management? Yeah, good. So we're getting lots of ones through. So again, this is really typical for a GP question. Is the big thing about GPs is trying to stratify like what is urgent, what is potentially cancer, and what is benign. So yes, we can deal with the benign stuff, but we also need to always be thinking like, is this a 2-week wait? Is this worrying? So yeah, urgent chest X-ray. In this case, so there are lots of things that make you sort of, it's very easy to need an urgent chest X-ray is basically what this slide is showing. So if you ever are, my way of doing these 2-week waits was if I'm worried, if I'm reading this and I'm like, then send them for a 2-week wait. And it normally works. So in this case, because actually learning this off by heart is kind of impossible. But essentially, I think we're over here. I was looking at this earlier. So offer an urgent chest X-ray if they have if they're over 40, they've never smoked, and they have 2 of. And in this case, it's prolonged cough and weight loss. So obviously, those are sort of your red flag symptoms. If they have one thing to keep in mind with the prolonged cough, which I think can be difficult, is that it is normal to have a prolonged cough for like up to 12 weeks after like the flu. And so that's why quite often you might see a lot of coughs being dismissed, but it's because they'll obviously, you get a feel for this, and you end up learning this just naturally off by heart when you're doing it in, day out. But essentially, these are your what's the word, referral criteria. As I said, I personally never learnt these off by heart. I just sort of, you get a really good feel for like what's worrying and what's not. So, question 8, Jenna is a 30-year-old breastfeeding lady who is not on regular contraception. She has had one episode of Oopsie 3 days ago. Her medications include salbutamol and an inhaled corticosteroid inhaler. She has had one previous episode of Oopsie in this cycle for which she took Ella-1. What is the most appropriate emergency contraception to prescribe? Ooh, I think this one's the first one that's actually kind of caught you guys out. I'm getting slightly mixed answers, but that's good. This one is so, like, this is testing everything about emergency contraception in one question. I was reading this, I was like, oh my gosh, there's too much. There's too much here to get through. So first of all, she's breastfeeding. She's not on regular contraception. That's important. So the time period is 3 days. She's got asthma. She's already had Ella-1 in the last cycle. So everything is going on here. And so I can understand why we've got lots of confusion. However, I do think overwhelmingly that you guys have, the majority have actually put the right answer, which is 3. So if in doubt, if you are ever like completely lost, just suggest a LARC, like a long-acting reversible contraception. So put the IUD, and it's almost always going to be right, because it's the most effective, and it's the most effective emergency contraception. It's not the most effective contraception. The most effective contraception is the implant, which is the one that goes in the arm. However, in the sense of emergency contraception, it's the most effective, and it's also, in terms of the timing, the one that has the most flexibility. So if you'll remember, Ella-1 is, you can take that up to 5 days after unprotected sex. Levonorgestrel, which is your Levanel, you can take up to 3 days after unprotected sex. And the IUD, you can take up to 5 days after unprotected sex, or 5 days after when you think they've ovulated, which sometimes gives you a little bit more wriggle room. And then it's also got the benefit of giving you that sustained contraception, because it means that they're contracepted for like 5 to 10 years now. Whereas with Ella-1 and with Levanel, that's only going to work for that single episode. And so, like, sexual health doctors are like obsessed with LARCs. Like, my mum won't stop talking about them. And so if you're in doubt, put a LARC. They love them. However, this does test everything. So breastfeeding. So because she's breastfeeding, you couldn't give Ella-1, which is your other Pristar, because, well, you can give it, but it's not ideal because she's breastfeeding, and it means that she can't breastfeed for those 7 days. Also, technically, apparently this has recently changed, but I was always taught that you can't give Ella-1 if like in the same cycle. So you can't give Ella-1 if they're already on hormonal contraception, and you can't give it if they've recently had Ella-1 or Levanel in the last cycle. Apparently this has changed, but the person who told me that is, as I said, my mom, who's the most up to date. So that one, I don't think that they'll test that fact, because UCL always say that if the guidelines have changed on one particular drug, that we won't test it, because it's unfair to know that, for you guys to magically know that. Because we've all been sort of taught this. Another thing about Ella-1 is that you're not meant to give it with asthma. However, that's only severe asthma. So in this case, she could have it, because salbutamol and like ICS is not really like classed as severe asthma. So it's more like if they're requiring like regular steroids, like oral steroids, or if they're on like montelukast. And then yeah, so I essentially, this one was like a real kicker. You guys did really well to still get the right answer, but it was very tricky. So yeah, this is a bit about the emergency contraception. I think I did go through quite a lot of this. Lebanel is difficult in the sense that you also have to change the dose depending on weight, but it is technically like, and I think it's out of the three, it's also the least effective. Um, and then one thing about the copper IUD is that people always say it may make your periods more painful and heavy, but it will. It will make your painful periods more painful and heavy. So don't give it to someone who already suffers from their periods. And yeah, I think we've covered that. Okay. So, question 9. Patrick is a 54-year-old man. Sorry, I've got a question. Well, I thought you couldn't give copper IUD if you had a previous upset in his cycle because of. Okay, so this is a good question. So just something about if we go back. So I thought you couldn't give a copper IUD if she's had previous upset in her cycle because if the fertilized egg has already been implanted, then that would count as an abortifacient. Um, Good question. So I would be leaning towards you can still give it because she took Ella 1. It wasn't like, oh, I had an episode of unprotected sex, but I didn't take any post episode medication. So if I think that's more for if they've just had it and they didn't do anything about it at the time, because then you're assuming it's a viable pregnancy still. Whereas if they've had Ella 1, there's like a very high chance that it's not that did not implant and didn't become a viable pregnancy. So I would be leaning towards it would be fine, but that is a good question and it's making me think. Okay. So, and thank you for your question. I enjoy these. You gotta make me think a bit more, you know? All right. Question 9. Patrick is a 54-year-old man who has started on Ramapril 2 weeks ago. Here are his repeat bloods. How would you manage him? Okay, we've got a couple answers. Yeah. Okay. All right. So most of you guys are all agreeing that we should continue the dose. There's a little bit of discrepancy between when we need to review or if we need to review. Before we move on to that, what two things are we looking at in this bloods that we want to check are normal when we're doing like ACE inhibitor reviews? Yeah, creatinine and potassium. So in this case, his potassium mildly raised, but it's not in the limits of where we'd be worried. And his creatinine, again, mildly raised, however, again, not in the limits that we would be worried. So you guys are right that we would just carry on and dose. However, NICE guidelines say review in 2 weeks. And so yeah, there. So the increase that you're looking for is more than a 30% increase. It's really good that you guys knew that because I personally only learned that when I was revising for my prescribing exam because it came up a lot in that. So you guys won't even need to revise that exam. You already know it. So this is everything about ACE inhibitor monitoring from the NICE website. So essentially, if they've got like a very small increase, we would suggest rechecking 1 to 2 weeks. Question? Najiha, no, it's not you. I can't see who has the mic on, but it's fine, it's gone off now. Okay. So yeah, basically you would stop it if it was above 30%, you would just monitor but keep it the same if it was below 30%. And then the cutoffs that you're looking for with potassium is your normal cutoffs. Is it above 5? Is it above like 5.5? And sort of how severe it is based off of that. Okay, so a little bit of ped/GP now. So question 10. Layla is a 3-year-old child who is brought into GP practice with her mother. The mother complains of her being increasingly withdrawn and pale. On examination, the GP feels a palpable mass in the abdomen. What should the GP do next? Yeah, good. You guys are very quickly answering this one. Yeah, so urgent referral to peds because what are we worried about? Yes. You're all correct. So acute lymphoblastic leukemia. I literally am the worst at hematology, but this one is if you get this question, obviously tragic for the imaginary patient, but great for you in your SBAs because you'll know there's only really one that they're going to be talking about. So this is a patient who's like under 10 years old who comes in looking pale. It's immediately that they're going for leukemia. The palpable mass is just like the cherry on top because it's talking about your hepatosplenomegaly. Maybe it's meant to be a distractor because you'd be thinking about like those other tumors, like Wilms tumor and like neuroblastomas. But essentially, to be honest, even if it was a different tumor apart from ALL, it's the same answer, which is urgent referral. This is, your basics of when you should be worried about a child. And it's very easy to get worried about a child. So just urgent referral to peds, no messing about. All right. Okay, so question 11. Isaac is a 6-year-old boy brought into GP with an acutely swollen left eye. On examination, it is red and warm. However, there is no reduction in eye movements. Given the likely diagnosis, how should Isaac be managed? Okay, I'll wait a little bit longer. So this is very important because I think there is a lot of debate about the right answer for this one, and I can see that reflected in your answers. I think the teaching on this is very confusing. So what do we think this diagnosis is? Yeah, preceptal cellulitis or periorbital, whatever you want to call it, same thing. So we think this is periorbital cellulitis. We know that because his eye movements, he can still do them and there's no pain on moving eye movements. That's like your typical orbital cellulitis sign. And so technically the way that you manage preceptal cellulitis is with oral antibiotics. However, there is a lot of it can very quickly progress from periorbital cellulitis to orbital cellulitis, like overnight. And it's a high risk condition because obviously the reason we're worried about orbital cellulitis is because you can end up with like a brain and it can track up to the brain. And so actually, this one is referral to A&E because they need IV antibiotics, but you're in GP, so you can't give IV antibiotics. So this one, I think, has caused a lot of debate. I actually saw this when I was in my peds placement, where a child came in and they'd been there the previous day on like the night shift, and the night shift team had sent them home with antibiotics. And she came back the next day and had orbital cellulitis. Her parents were literally shouting at the doctors. It was like a whole mess. They were like, "This is really bad. We're really sorry. It happens because." Like it was the end of a week of night shifts and we're already overworked, but this was a mistake on our part and we're really, really sorry. Please don't sue us. Anyway, so this is how I learned this lesson. I think you'd refer them to secondary care so that at least the first few doses would be IV, just to make sure you've controlled that infection and that it's not going to progress to orbital. And then you would send them home on oral. But you would never, especially as a GP, you would never make that decision yourself of this is fine and I'm going to send you home because if you send them home and then they go to A&E with a raging infection, that's just so dangerous for them. So this is something that I've actually seen come up. So this is not your fault if you got it wrong because I think that the messaging here is not clear. The teaching is not clear, and I remember seeing on QuesMed questions like this where they said oral antibiotic, and I wrote like an angry email being like, "You can't do this." Every pediatrician I've spoken to has said, "Please don't do this." So I think that this is a problem in the system that needs to be sorted out, but it's good that we have covered it here. None of you guys are gonna ever send someone with periorbital cellulitis home on orals. You're gonna send them to the pediatricians, and then you know what? Like, what's the harm? What's the harm of sending them to pediatric A&E and then the pediatrician makes that decision for you? But at least then you know that they have gotten like, a specialist who is very confident in this area, hopefully has dealt with them and probably has admitted them for some IVs. Okay. I'm like so passionate about that, so I'm glad I got that over with because I was so looking forward to that question. Okay, question 12. A 19-month-old boy has been crying and tugging at his left ear for the past couple of days. On otoscopy, you see this bilaterally. So you could see this. All right, so what is the most appropriate management? Okay, once again, you guys have impressed me because I thought this would be harder than it seems to be. You're almost all getting this right, and I thought this was very split. Okay, so it is in fact three. The reason being that actually a lot of these reasons are fair. So normally we don't necessarily treat them, or we wouldn't treat them because they've only arrived in the last 2 days and it's, you wait to see if it's worse. But the reason that we treat in this case is because they're more high risk. And being that it's because they're under 2 years old and it's bilateral. The other reasons that you might prescribe amoxicillin would be, for example, if they were like systemically unwell. There's a whole list on the next slide, but just yeah, something about you wouldn't send them for grommets because this is like just I think this is just a one-off. You only really send them for grommets if they're having repeated otitis media, from my understanding. And then yeah, the eardrops aren't going to get to the root of the infection. You actually need amoxicillin. Okay, so normally otitis media is self-limiting. It's normally, as it said on the other side, viral. But antibiotics should be prescribed if it's lasted for a while, if they're systemically unwell, if they're immunocompromised, or if they have like high risks of it like tracking somewhere. So, for example, a patient with Down syndrome is one of your like high risk things because of the um, physical like slight differences in the anatomy. Makes it more likely to become serious. Younger than 2 years with bilateral, which is like a very specific thing. That's why I was so surprised you guys all got it right. But go you. Otitis media with perforation and or discharge. And then it's just your simple amox normally. All right, question 13. A 7-year-old boy is brought into A&E with abdo pain and vomiting. His mother notes that he has lost some weight over the last few weeks and has had a fever. Which is the next best investigation to confirm the likely diagnosis? Hmm. Okay. Okay, so mixed answers again. Before we go on to the answer, what is the like presenting? What is the presentation here? Yeah. So this is a type 2 diabetic, well, type 1 diabetic, sorry, who's presenting probably for the first time with diabetic ketoacidosis. So good for spotting that. It's your typical abdo pain, vomiting. They've lost weight because they're diabetic, and then the fever is probably like they probably have an infection, which is what's tipped them into DKA. Now the best investigation, I think, so I've had some ones, I've had some twos, I've had some threes, and I know what you guys are trying to get at. So ideally, what information do you need to diagnose DKA? Like, what are the three criteria for it? Okay, so your three are high glucose, ketosis, and your acidosis. It's all in the name pretty much. And so we need one thing that will confirm all three. So urine dip, you can rule that out because it will only show you the ketones are high, but it won't show you necessarily. It might show you like the sugar in the blood, but it won't show you like that it's high blood sugar, and it won't show you like that they're acidotic. And then I would say it's between one and three. That so I agree with this answer for the record, but I do think that this is also fair. So I think I would also do a VBG. Reason being that they don't have respiratory problems, so I wouldn't do an ABG, especially on a 7-year-old. Like unnecessary ABGs, especially on a child, that pediatricians are not into that. That's not their thing. So they wouldn't probably do this, to be honest. Urine dip, yes, it would show you ketones, and so that is useful, but actually you should be able to get blood ketones from your VBG. And so actually you might only need the VBG to in one shot get all three because you'll know that they're acidotic, you should see that the ketones are high, and you should have the glucose reading on that. And so it's VBG, but I can see why some of you did put ABG. I think even here it says possibly. I thought I was reading this earlier and it said ABG, but I think I maybe read ABCs. Okay, but so yeah, fine. So I agree. I think it would be your VBG. So this is just a bit about your DKA management. So I probably shouldn't have shown you this because I was going to ask you guys how you manage DKA, but oh well. So yeah, you want to basically fluid hydrate them first because they're going to be really, really fluid deplete, and then you want to give them your insulin dextrose, and also monitor their potassium. You don't really need to know, like it is slightly different whenever you do peds compared to your adult DKA. So I don't think you need to know exactly what you do with peds compared to adult, but just I would know like 10 mils per kilograms is like your bolus, like your emergency bolus, and that's for everything, to be honest, 10. So that one's useful to know. And then the other thing that makes DKA different in adults and children is that it's just so much more high risk for cerebral edema because children are much, much more sensitive to fluid shifts. So that's just one other thing that I would really want you to take away from like specifically pediatric DKA. But apart from that, it's a good revision of DKA. And actually, in my 5th year exams, diabetes came up in my OSCE, and I didn't really expect it to because I was like, that's really like endo, that's a 4th year topic, but it came up. So don't ignore diabetes. Okay, so question 14A. We're about halfway now, by the way. I can either stop at 7 or and like give you guys a 5-minute break, or we can just carry on. You guys can let me know. But just like drop it in the chat what you'd prefer. But 14A. Baby X is a 3-hour neonate born at 33 weeks via emergency C-section due to placental abruption. Baby X has been grunting since birth and has intercostal recessions. What should the mother have been given to reduce the risk of this complication? And we do have lots of answers already. You guys are very on it. So yes, it is your IM dexamethasone. So we normally try and do this very like the thing is if it's unexpected. Okay, the thing is, this wording of the question makes it sound like we like messed up. To be fair, if it's unexpected, there's no way that like if we suddenly given them IM dexamethasone just as they would give doing the C-section, that probably wouldn't have done anything. But what we do is in high risk people, we do plan to give IM dexamethasone. So it's sort of, to be fair, in this case, it's not like we made a mistake. It's just that we weren't given the time to do that. And what would have helped would have been the dexamethasone. So in patients that have a very high risk of having a premature birth, this is what we do to try and reduce the risk. And the reason being that we're trying to reduce the risk of neonatal like respiratory distress. And that's because, oh, no, they don't have, maybe there wasn't, I thought there was a slide there. So essentially, if they premature, they won't have enough surfactant, and surfactant helps with the surface tension so that the lungs are able to open and like inflate and breathe. right? If there's not enough surfactant, essentially your lungs just cannot inflate properly. It's like the only thing I remember from first year physiology. And so I love flexing on that fact, even though you guys all know it. But yes, so it is your steroids will help with that. Okay, and then this is sort of a carry on from the previous question. So what does respiratory distress syndrome, what should we be giving them in order to prevent future respiratory complications? Okay. Yeah. So you've mostly all gotten it right. So it is that you would want to give this vaccine. And what are we trying to prevent against? Yeah, really good. So I've got RSV, I've got bronchiolitis. These are both correct answers. So we are trying to prevent RSV infection because that causes bronchiolitis. And your RDS babies are more risk, essentially, of having really severe bronchiolitis. And so that's why they're the only ones who really we give this to. So we can give this. And then in terms of continuous surfactant, not a thing. But also your babies will start producing their own surfactant quite like all we're trying to do with the IM dexamethasone is stimulate that their own production. It's not like it's something that the mother is creating for the baby. We're just trying to stimulate that baby's production. And so really it should be fine. Um duh, 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 duh. Yep. Yeah. I mean, obviously not vitamin K and antibiotics we don't necessarily do. All right, so a little bit about bronchiolitis. So as I said, it's mainly RSV. It tends to be like your 18-month-old is like your typical question. I have seen like a 12-month-old with it, but I haven't seen anyone older than 2 with it. And 12 is like the youngest I've seen. So like 15, 18, those are like your like top months really to be getting it. And it's essentially like respiratory distress. So they might have difficulty breathing, your nasal flaring, your like intercostal recessions and things like that. They might not be able to feed properly because they're out of breath and also because they're like quite irritable because they're sick. They might have a fever, they might have wheeze. So it is generally, there's not a lot we can actually do about it because it is a virus. However, we are likely to do something about it because it can just be so severe. So even though we're not doing much, we just want to be there just in case things go really sideways really quickly because babies can crash very quick. And so it's something to like take seriously, even though it's not something that we can actually help that much with. It's sort of, you know, a bit like an oxymoron or something because obviously you'd think with supportive treatment that you can send them home, but you can't. You need to support them, but in hospital. And yeah, with these ones, the main one that I always found in SBAs was the way that you kind of differentiate this from croup is okay, number one, they'll say bark and cough, but also I think croup tends to affect slightly older children than 2 years, whereas bronchiolitis will be very specifically like young. Um, and then also, this is interesting, like the whole peak and trough of bronchiolitis. So sometimes parents might come and bring them on the peak of their sickness. And so they'll say they've been unwell for the last 3 days or the last 5 days. And when you're looking at your patient, you're thinking this is the worst it's going to get. Whereas if they come on the first day and they don't seem that bad, but it will get better before it gets worse. So sometimes the doctors, like the way that they reason as to whether who they admit and who they don't is very much based on this peak and trough thing. So just pay attention to that. If you haven't had your PEDS placement yet, then like, take note of that because I used to be a bit confused about like, why are you sending this person home and not this person? And they explained this whole thing to me. Okay, so question 15. A 7-week-old baby has been brought into A&E by its mother. She says he projectile vomits the milk after feeding, and she's worried he's not eating enough. Examinations and investigations, including an abdominal ultrasound and blood gas, were normal. What is the most likely diagnosis? Ooh, okay. I think we've managed to trip you guys up. I think it's about 50-50 between 4 and 5. So this actually happens a lot. So in the sense that loads of people come in bringing their babies, being like they're vomiting, And it's very difficult because babies vomit. Like babies vomit, that's normal. And sometimes it's very difficult to know, is this normal or abnormal vomiting? So the things that you want to ask, and this is why taking a good history is really important with peds, is like, what color are they vomiting? How quickly are they vomiting after their feed? Have they lost weight? Are they like unhappy in general? Like are they, more irritable? Things like that. And then obviously you've got your examination, you've had a look at them physically, you've looked at, do they seem malnourished? Do they seem like, dehydrated? And then you've done your abdo ultrasound and your blood gas. So everyone who's put five, I know why you put it because we've said that they projectile vomit. However, like when we're talking about pyloric stenosis, we mean they projectile vomit like 20 meters. Whereas a lot of people, a lot of parents will just say projectile vomit when they mean vomits like a normal baby, but because people, they don't necessarily know how much a baby vomits, and it does feel projectile when it happens as often as it does. So this is why like this one's really tricky. But the thing to check here is that their blood gas is normal, which means that they're probably stable in terms of their acid base balance. Their abdo ultrasound is normal, which kind of rules out your intussusception, and their examination is normal. And quite often with pyloric stenosis, I feel like they do say like you can feel a little bit of like a hard like olive. I think that isn't that the finding. So that's sort of where we now get on to number 4, which is essentially much more common, but is actually not such a problem. So they're vomiting immediately, but they're otherwise totally fine. And it's clinical diagnosis, and you just give them some little baby PPIs or something. All right. Yes. So yeah, you can always like just test it out and like give the baby some milk and then observe them for an hour and see what's coming up. But yeah, so this one was quite difficult, I thought. So question 16. A 2-year-old toddler is brought in by her mother as she is very sensitive to sound. Her mother says that when she hears loud noises, she becomes very distressed and starts rocking back and forth. Her mother says she's able to communicate with her, but on further clarification, you find that she only uses one-step commands. She's able to run and build a tower of 6 blocks, but does not do this when other kids are around. What is this toddler likely to have? Yeah, so I think the general consensus here is that this is autism. So I think that the most obvious ones that you're trying to distinguish between, so we know it's probably not cerebral palsy because it's not affecting her motor functions so much, like she's able to run. They haven't mentioned any difficulties with motor. Um, Unlikely to be OCD, it just doesn't really fit that picture. I think it could, you're reasonable to consider that it might be a normal variant of development, can't say it, developmental delay. However, it's not affecting all of them equally, if you get me. So, you know, it's maybe affecting their speech, but it's not affecting their function and their like building abilities. I've forgotten what that's called. Their cognitive function. I don't know. I was kind of split between 1 and 5, but it is autism because Asperger's doesn't tend to have a language delay, whereas autism might. So a little bit about autism. So it's a triad of abnormalities. They normally emerge quite early on, but they're not always identified. So it might be like a kind of in retrospect, actually, yeah, they were always like quite, maybe by themselves in the playground and things like that. So, sometimes it doesn't get picked up super easily. So it's an impairment in the social communication, in language and understanding, and it can be associated with like restrictive and repetitive interests. It's related to like significant impairment in their social functioning, but it shouldn't necessarily be linked to like intellectual disability or global developmental delay. So if there is intellectual disability or global developmental delay, where they're just developmentally delayed in every aspect and not just the social, then it's probably not autism, it's something else. Or it could maybe be things stacked on top of each other, but I think then it's getting a bit complicated. And then the management is very like, holistic. It's about your MDT approach. So it's about offering support to the family, education, not only for the child, but for the parents and the people around them about how to like help their child flourish as much as they can. Sort of interventions to do with you know, helping them be more settled. Maybe it requires salt and OT input, but maybe not. This is apparently how it's like diagnosed. I don't think you need to know that. I've never heard of it before doing this. And then just, yeah, you do need to learn your developmental delays. They're like kind of high yield. Um, I'm trying to think. There were little tips that I learned when I came to my exams. So I don't know, like the rule of threes with the blocks. So for example, that's like one of the ones that I still remember, which is the tower blocks, is that it's like if they're 2 years old, they should be able to do 2 times 3. So they should be able to do 6 blocks. If they're 3 years old, they should be able to do 9 blocks. Um, Apart from that, I unfortunately cannot help you too much with that because it's just rote learning, and that's what I had to do. All right, question 17. A 7-day-old baby, exclusively breastfed baby. That was poorly. Yeah, a 7-day-old exclusively breastfed baby is brought to see you with difficulty in feeding over the past 24 hours. He was born at 37 weeks, induced at 24 hours after premature rupture of membranes. After a period of observation, there were no concerns and they were discharged. Over the past 24 hours, he's been less interested in feeding. And he seems uncomfortable. He keeps pulling away. Mum also states that he seems to be grunting after he exhales. So based on this history, what is your most likely diagnosis? You guys are really quick. So yes, it is neonatal sepsis. And essentially, yeah, babies and children in general, but especially babies, do not present with an infection in the normal ways that you would expect an adult or an older child to present. And so essentially, if a baby is just off for no reason, like the first thing you need to be thinking about is neonatal sepsis, especially because he's only 7 days old. And so it's still within sort of, quite a high risk time period. So yeah, it should be considered. It's not that it necessarily is, but it's that it should be considered. So I've seen lots of people obviously have the full septic stream, and it's just nothing to do with that. However, they all get that full septic stream because you've got to be like really, really suspicious, high index of suspicion. In terms of the protein allergy, it's also a good option, but it wouldn't be like it wouldn't present in the same way. Normally it presents with like diarrhea. And then GORD, we've talked about it, it's more like you're vomiting. Physiological newborn feeding. So they can lose up to 10% in the first 10 days. But I mean that I don't think it's even said that he has lost weight, but it shouldn't actually be because they've got like different feeding habits. It's just because of things. I don't know. It's things. And then neck, not how it presents. So question 18. A 6-month-old child is brought into the GP practice by his mother due to a rash on his foot. The GP prescribes emollients for this condition and it settles. A few months later, the child comes back into the practice with a vesicular painful rash and a fever. What is the management of the likely complication of this condition? Yeah, really good. Everyone's gotten it right. So it is your AV acyclovir. Does anyone know what sort of the underlying and then what this condition is like meant to be? So there's sort of two conditions that we're covering here a little bit. Yeah, perfect. So eczema and then eczema hepaticum. So your sort of eczema mixed with herpes is very dangerous. And so that's why we're giving like your IV acyclovir. Before that, yeah, it's just meant to be your regular eczema. We've given them some emollients and it's gone away. So in terms of, we wouldn't really give steroids in this case. Like that might be used in eczema, but not in eczema hepaticum. And then the ophthalmology referral is an important thing to consider. It's just about the distribution of where the rash is. So if it's sort of near the eye and on the face, then you might consider an opthal emergency. And then, yeah, this is just I'm sure you guys all know that this is just a fun fact that like eczema presents very differently in children as it does in adults. So like in babies, it's more on the extensors instead of the flexors. Great job. Question 19. So Jane has been ill for the past 4 days and has had to miss work as a result. She's worried about repercussions from her employer, and on advice of her friend, she has called the practice asking for a fit note. What is the most appropriate answer regarding this request? Yeah, perfect. I think this actually did come up in my finals in fifth year. So, and it's just like, it's easy marks, easy marks. So, FitNote, yes, they can self-certify for the first 7 days. Obviously, it's different and it's more difficult if they're like self-employed, but in this case, they're not. So, yeah, self-certify, easy. And it's after that, they'll need a GP. Question 20. A 6-month-old breastfed baby has recently been introduced to solids. Overall, there have been no concerns since birth. However, during the health visitor visit, the baby has gone from their 76th centile to the 62nd. On further questioning, it's found that the baby has had episodes of diarrhea. What investigation will reveal the likely diagnosis? Yeah, really good. So everyone's gotten the right answer. What do we think that this is, the diagnosis? Yeah, very, very, very quick. I got those answers really quick. Yes, perfect. Celiac. So the reason being that it's just like this huge drop in weight. So that's essentially what we call failure to thrive. And especially with the diarrhea, you could maybe ask the parents about like, oh, does it have like a particular like is it particularly smelly? I'm not sure if that's a helpful answer if that's the only baby they've ever had because they really don't have anything to compare it to. But yes, it will be your so in this case, it's because so this is really interesting about it's because they've been introduced to solids. So previously they were fine, and it's because they were fine on the breast milk, but now that they're trying solids, it's setting off their sort of autoimmune condition, and so they're now failing to thrive. And so the simplest thing, like the actual diagnostic, is your biopsy, but the first thing you'll be doing is your anti-TTG and your IgA. Okay, so we're on to the last three questions now. So you guys are doing really well. Stay with me for like, I don't know, 10 more minutes. So, question 21. A 22-month-old child is brought in by ambulance after her mother witnessed her making jerky movements for approximately 3 minutes. On further questioning, the child had coryzal symptoms, a fever, and reduced appetite in the preceding few days. Blood glucose was in the normal range. Given the likely diagnosis, what is the most appropriate advice to be given to the parents? Yeah, you guys have all answered again very quickly and all correct. So, yes, it is four. So, this is your febrile seizure. I mean, this never actually came up, but I think this would be so Oscarable just talking to to a parent who's concerned about like, no, this doesn't mean that your child has epilepsy. Yes, it can happen again. Yes, no, it will not help for you to give them paracetamol because sometimes these can happen after the fevers happen. Sometimes they can even happen before the fever. So they seem to be related to the fever, but there's no evidence that trying to get rid of the fever by giving them paracetamol or like Calpol will make any difference. So there's no point in doing that. You only give them antipyretics if they're miserable and it helps them symptomatically, but it won't stop them from having a seizure. They wouldn't need referral unless it was a complex febrile seizure, but in this case, it's pretty simple. And yeah, you guys know it's 5 minutes. 5 minutes is when you're starting to worry, and so you always just want to finish off any like consultation about febrile seizures, saying, if this happens, make sure that they don't hurt themselves. Make sure you move it. Don't let them fall off a bed or anything like that. Make sure that they're safe, but then also put a timer on, observe them. If you're worried, call an ambulance. All right, question 22. So, what is the most likely cause of osteomyelitis in children with sickle cell anemia? Yes, lots and lots of answers coming through. So, brilliant. So, it is your salmonella. What is your most common cause of osteomyelitis in just a child that doesn't have sickle cell anemia? Yes, I've got one through. So, Staph aureus. Yeah. So these are your two to really learn. Um, I've not heard of that. That sounds kind of fun. But yeah, just learn Staph aureus for pretty much everyone else, and then Salmonella just for your sickle cell patients. And then a final question. So a 30-year-old female presents to her GP complaining of weakness, a headache, and nausea. She has a past medical history of hypothyroidism, depression, hay fever, and asthma. The GP orders some bloods. What medication is likely causing her symptoms? Yeah, this is a really tough question, and you guys have all gotten it right. Okay, so we know that this patient probably had, well, what do we think that this patient has, like as a condition? Yeah, so their symptoms are related to hyponatremia. Specifically, um, in this case, we're looking for a drug that causes hyponatremia, and we're looking at fluoxetine. So your SSRIs can cause SIADH, which is a cause of euvolemic hyponatremia. And so whenever you have a hyponatremic patient, you want to do a fluid assessment. We haven't mentioned anything here. You can kind of just assume that she's euvolemic, and also just based off of, like, you can just do it based off the drugs. But yeah, in an ideal world, we would have kind of pointed you specifically towards SIADH. But yeah, so clinical features of hyponatremia is like headache, weakness, nausea. It can obviously progress into confusion, coma. I recently saw a woman who had a sodium of 101, which is shockingly low. And I'm actually shocked that she wasn't in a coma. She was just super confused. And then I saw her after her sodium was um, sort of corrected, like a completely different person. So very interesting. I literally didn't know people could exist with a sodium that low. But yeah, all right. So that is our session done. Thank you guys for sticking with me. Um, if you've got any questions, now's the time to ask. And please do fill out the feedback. It would be very useful. Next week, we're covering Mod B, and I will also be there, which I'm hoping does not put you guys off. So hopefully I'll see a lot of you guys next week. And yeah, please fill out the feedback so I can get better for next week then. Um, I In terms of the recording, I do not know. I don't know whether I think they just drop them into like the chats where you found out about this. Wait, let me stop recording actually. Stop recording.